The 1918 influenza pandemic, Spanish flu.
In the spring of 1918, an unusually severe flu swept through military training camps in the United States. Fort Riley, Kansas, reported hundreds of cases of influenza that was far more aggressive than typical seasonal flu. Doctors noticed something alarming. This flu was killing young, healthy adults, not just the elderly and infants who typically died from influenza. Mortality rates among soldiers were disturbing. Medical officers documented the outbreak and reported it up the chain of command. Then the virus appeared in military camps across the US and Europe. Soldiers packed into barracks, trenches, and transport ships. The conditions were perfect for a respiratory virus to spread explosively. Public health experts knew a dangerous influenza strain was circulating. They understood it was spreading through military movements. They recognized the threat.
But World War I was reaching its climax. Military operations couldn't stop. Troop movements continued. Public morale had to be maintained. Most importantly, wartime censorship prevented honest reporting about the flu. Newspapers in combatant nations were forbidden from publishing information that might harm morale or reveal military weakness. Stories about soldiers dying from disease didn't support the war effort. Spain, which was neutral in World War I, didn't censor its press. Spanish newspapers reported on the flu outbreak honestly. This created the misleading impression that Spain was particularly hard hit, giving the pandemic its name, the Spanish flu. In reality, the virus was everywhere. Spain was just the only country being honest about it. Without accurate public information, people didn't understand the danger. Public gatherings continued. Parades celebrating the end of the war packed millions of people together. No coordinated public health response existed. Cities made isolated, inconsistent decisions about closures and gatherings.
The spread. The virus spread in 3 waves. The first, in spring 1918, was relatively mild. The second wave, in fall 1918, was catastrophic, killing millions in a matter of weeks. The third wave, in winter and spring 1919, killed millions more. The virus moved with astonishing speed. A city might have a few cases one week and thousands dead the next. Hospitals were overwhelmed. Morgues ran out of space. Bodies were stacked in warehouses. Entire families were wiped out. The pandemic killed disproportionately among young adults, aged 20 to 40, people in the prime of life. This pattern was unusual and horrifying. Pregnant women faced particularly high mortality rates. The consequences.
Best estimates, 50 to 100 million people died worldwide, more than were killed in World War I itself. Some communities lost 10 to 20% of their population in a matter of months. The pandemic disrupted societies globally. Economies collapsed. Orphans numbered in the millions. The psychological trauma was immense. And yet, despite being one of the deadliest events in human history, the 1918 pandemic was quickly forgotten. Few memorials exist. It became a historical footnote, overshadowed by the war. The lessons that should have been learned about the need for honest public communication, coordinated public health responses, and pandemic preparedness were largely ignored until the next pandemic came. The pattern begins. Wartime censorship and prioritizing morale over public health turns epidemic into catastrophic pandemic. The HIV/AIDS crisis, 1981 to the 1990s.
In June 1981, the CDC published a report about 5 gay men in Los Angeles who had developed a rare type of pneumonia typically seen only in people with severely compromised immune systems. By the end of 1981,
422 cases of what would become known as AIDS had been reported. Young, previously healthy men were dying from infections that healthy immune systems should easily fight off. Doctors and researchers immediately recognized this was something new and dangerous. They didn't know what caused it yet, but they knew an emerging disease was killing people and spreading. The pattern was clear. The disease was transmissible, it destroyed the immune system, and it was fatal. Early epidemiological work identified transmission routes: sexual contact, blood transfusions, shared needles. Scientists raised alarms. Public health officials requested funding for research and prevention programs. The gay community organized and demanded action. The Reagan administration largely ignored the epidemic for years. President Reagan didn't publicly mention AIDS until 1985, 4 years into the crisis, and after more than 5,000 Americans had already died. His press secretary joked about the gay plague during press briefings. Requests for funding were denied or severely limited. The reasons for this neglect were clear and tragic. The disease primarily affected gay men, intravenous drug users, and Haitian immigrants, marginalized communities with little political power. Meanwhile, the virus spread. Blood banks weren't properly screening donations. Safe sex education wasn't happening. Needle exchange programs were blocked. Research funding was inadequate. Public health experts knew exactly what needed to be done. Massive education campaigns, funded research, destigmatization, testing and treatment programs. Almost none of this happened during the crucial early years.
The spread. By 1985, every region of the United States had reported cases. The virus had spread to every continent. Blood transfusion recipients, including hemophiliacs, were infected. Heterosexual transmission was documented. The epidemic that had been dismissed as a gay disease was now affecting everyone. But by then, hundreds of thousands were already infected, and the virus had established itself globally. In sub-Saharan Africa, the epidemic grew unchecked for years with minimal international support.
The consequences. Over 40 million people have died from AIDS globally. Millions more live with HIV today. Entire communities were devastated. In some African nations, life expectancy dropped by decades. The delayed response had direct, measurable impacts. If education and prevention programs had begun in 1981 instead of years later, hundreds of thousands of lives could have been saved. Activists from organizations like ACT UP had to fight, protest, and die to force governments to take action. The research and treatment that eventually came saved millions, but it came too late for the people who died waiting. The AIDS crisis taught brutal lessons about what happens when public health is subordinated to stigma and political expediency. Those lessons would need to be relearned with future pandemics. The pattern continues. Stigma and discrimination delay response.
The 2003 SARS outbreak. In November 2002, cases of an unusual respiratory illness appeared in Guangdong Province, China. Doctors encountered a pneumonia that didn't respond to standard treatments. Patients were dying. By February 2003, hundreds of cases had been reported internally within China's health system. This wasn't normal flu or pneumonia. It was something new and spreading rapidly. Dr. Carlo Ubani, a WHO infectious disease specialist in Vietnam, identified a case in Hanoi and recognized it as a novel and dangerous disease. He immediately alerted international health authorities and began contact tracing. The warning was clear. A new respiratory disease with high mortality, human-to-human transmission, and pandemic potential had emerged. The Chinese government initially suppressed information about the outbreak.
Journalists who tried to report on it were silenced. International health authorities weren't informed. China denied WHO inspectors access to Guangdong. Dr. Zhang Yanyong, a Beijing military doctor, became a whistleblower, revealing that the Chinese government's public statements drastically understated the scope of the outbreak in Beijing. His courage forced transparency, but only after crucial months had been lost. During those months of cover-up, the virus spread. Infected travelers carried SARS to Hong Kong, Vietnam, Singapore, Canada, and elsewhere. By the time the international community fully understood the threat, SARS had seeded outbreaks across the globe.
The spread. A single infected doctor staying at Hong Kong's Metropole Hotel transmitted the virus to at least 16 other guests. Those guests then carried SARS to 5 different countries, creating simultaneous outbreaks. Healthcare workers were particularly vulnerable, treating SARS patients without knowing they were dealing with a novel, highly contagious disease. Dr. Urbani himself contracted SARS while treating patients and died in March 2003. Toronto experienced a major outbreak. Hospitals implemented emergency quarantine procedures. Singapore and Hong Kong saw widespread transmission. Vietnam acted quickly and contained its outbreak, but other locations struggled.
The consequences. The 2003 SARS outbreak infected 8,096 people in 29 countries and killed 774, nearly a 10% mortality rate. The outbreak was eventually contained through aggressive public health measures: isolation, quarantine, contact tracing, and infection control in hospitals. These measures worked, but they had to be implemented under crisis conditions because early warnings had been suppressed. SARS caused massive economic disruption, estimated at $40 to $50 billion globally. Tourism collapsed in affected regions. Supply chains were disrupted. The psychological impact of quarantines and fear was immense. Most importantly, SARS was a near miss. If the virus had been slightly more transmissible, or if initial suppression had lasted longer, the world could have faced a catastrophic pandemic. The international community claimed to learn from SARS. The international health regulations were updated. Early warning systems were promised. Transparency was emphasized as critical. Those lessons would be tested again with COVID-19. Many of them would fail. The pattern: government cover-up delays international response. Virus spreads globally before containment possible.
The 2014 to 2016 West African Ebola epidemic.
In December 2013, a 2-year-old boy in Guinea died from a mysterious illness. His death marked the beginning of what would become the largest Ebola outbreak in history. By March 2014, Médecins Sans Frontières, MSF, or Doctors Without Borders, was treating unusual hemorrhagic fever cases. They tested samples and confirmed Ebola, a virus with mortality rates between 25 to 90%, depending on the strain and quality of care. MSF immediately raised international alarms. They warned that this outbreak was different. It was occurring in urban areas, not remote villages. It was spreading across national borders. Standard containment methods weren't working. They called for massive international mobilization: medical personnel, supplies, treatment centers, contact tracing infrastructure. They were specific about what was needed and how urgent the situation was.
The World Health Organization didn't declare a public health emergency of international concern until August 2014, 5 months after MSF's initial warnings and 9 months after the outbreak began. By then, the virus had established itself in Guinea, Liberia, and Sierra Leone. It was spreading in major cities. Healthcare workers were dying. Burial practices were amplifying transmission. Health systems were collapsing. The reasons for delay were complex. WHO was underfunded and overstretched. West African health infrastructure was weak. International attention to African health crises was limited. Economic concerns about travel restrictions and trade affected decision-making. But fundamentally, the international community treated an African outbreak as their problem, rather than a global threat requiring immediate mobilization. When international help finally arrived in late 2014, the outbreak was already raging. Treatment centers, protective equipment, and trained personnel that could have contained the outbreak in early 2014 arrived months too late.
The spread. Ebola spread through 3 countries' healthcare systems. Hospitals became amplification centers. Patients came for treatment and infected healthcare workers and other patients. Traditional burial practices, which involved touching the deceased, transmitted the virus to family members. Fear and distrust of healthcare workers, partly justified by inadequate treatment facilities, drove people to hide cases and avoid medical care. The virus reached major cities, including Monrovia and Freetown, where population density accelerated spread. Urban transmission of Ebola was unprecedented and terrifying. Several cases were exported internationally, to Nigeria, Mali, and even the United States and Spain, creating panic and revealing how unprepared even wealthy nations were for highly infectious diseases.
The consequences. By the time the outbreak was declared over in June 2016, more than 28,000 people had been infected, and over 11,000 had died. The true death toll was likely higher because many cases went unreported. Healthcare systems in Guinea, Liberia, and Sierra Leone collapsed. Healthcare workers, a precious resource in countries with few doctors, died by the hundreds. Routine medical care stopped, causing deaths from preventable diseases. Economies crashed. Schools closed. Social structures broke down. Orphans numbered in the thousands. The psychological trauma, watching loved ones die horrible deaths, fear of touching anyone, persisted long after the virus was contained. The international response, when it finally came, was effective. MSF, the CDC, WHO, and various nations deployed resources that brought the outbreak under control. But those resources, deployed in March 2014 instead of September, could have prevented thousands of deaths. The pattern: treating outbreak in poor countries as their problem. Delayed international response. Exponential spread before mobilization.
COVID-19 pandemic, 2019 to 2023.
In late December 2019, doctors in Wuhan, China, began seeing patients with a mysterious pneumonia that didn't respond to standard treatments. Dr. Li Wenliang, an ophthalmologist, warned colleagues in a WeChat group about a SARS-like illness. The Chinese government reprimanded Li Wenliang for spreading rumors and forced him to sign a statement recanting his warnings. He later contracted the virus while treating patients and died in February 2020. By mid-January 2020, Chinese scientists had sequenced the virus, SARS-CoV-2, a novel coronavirus. They published the genome. Evidence of human-to-human transmission was confirmed. The virus had pandemic potential. International public health experts immediately recognized the threat. They had seen this before with SARS. They knew what exponential spread of a respiratory virus looked like. They warned governments to prepare. The early response was plagued by familiar problems. In China, initial suppression of information, delayed acknowledgement of human transmission,
reluctance to share data transparently with international health authorities. Internationally, the WHO was slow to declare a public health emergency of international concern, declared January 30th, 2020, and didn't use the word pandemic until March 11th, 2020, by which time the virus was spreading on every continent. In many countries, governments delayed action, hoping the virus would be contained elsewhere. Economic concerns, tourism, trade, business operations influenced decision-making. Testing capacity was inadequate. Stockpiles of protective equipment were depleted and not replenished. In the United States, despite having pandemic playbooks developed after previous outbreaks, the response was chaotic and delayed. Testing was limited. Messaging was contradictory. Federal coordination was weak. Partisan politics influenced public health decisions. The pattern from previous pandemics repeated. Early warnings were dismissed, experts were ignored, economic concerns were prioritized, and by the time aggressive action was taken, the virus had already established community transmission.
The spread. COVID-19 spread globally with terrifying speed. Within 3 months of initial cases, the virus was on every continent except Antarctica. Countries that acted early and aggressively, like New Zealand, South Korea, Taiwan, and Vietnam, successfully contained or minimized initial waves. Countries that delayed, including the US, UK, Italy, Spain, and Brazil, experienced catastrophic first waves, with overwhelmed hospitals and mass casualties. The virus's characteristics, pre-symptomatic and asymptomatic transmission, aerosol spread, long incubation period, made containment extraordinarily difficult. But early, aggressive action demonstrably saved lives.
The consequences. As of early 2024, COVID-19 has caused over 7 million confirmed deaths globally. Estimates of excess mortality, total deaths above expected levels, suggest the true toll may be 15 to 20 million or higher. The pandemic disrupted global society in unprecedented ways. Lockdowns, business closures, school shutdowns, supply chain collapse, economic recession, social isolation, mental health crisis. Healthcare systems were overwhelmed. Healthcare workers died by the thousands. Routine medical care was delayed, causing indirect deaths. Long COVID has disabled millions. The development of vaccines in record time was a scientific triumph. But distribution was inequitable. Wealthy nations vaccinated their populations, while poorer nations waited. Vaccine hesitancy, fueled by misinformation, allowed preventable deaths. The pandemic exposed and amplified existing inequalities. Marginalized communities, racial minorities, low-income workers, immigrants, the elderly in care facilities suffered disproportionately.